Tonight's presenter is Dr. Rondeau. He is one of North America's most sought-after clinicians, and he has been lecturing over 100 days per year for over 35 years. Over 20,000 dentists have attended his course and study clubs and conventions worldwide. He has an extremely busy practice, which is limited to the treatment of patients with orthodontic, orthopedic, TMD, and snoring and sleep apnea problems. He has 5 diplomas, 1 in ortho, 1 in TMD, and 3 in sleep. Without further ado, here's Dr. Rondeau.
Good evening, everybody. Thanks for coming. And tonight we're going to talk about early orthodontic treatment. And it's a subject which all general dentists should be aware of. Now, of course, Space Maintainers is a lab that's built on functional appliances. So I've had the pleasure of working with Space Maintainers for at least 25 years. And so it's an excellent lab and have excellent courses, and I'm happy that they invited me to do this webinar with you tonight. So I want to talk about functional appliances. And I have fixed and removable functional appliances. I think the general dentists need to start treating in the mixed dentition because the majority of orthodontists don't. Now, it's more and more orthodontists are doing it, but still the majority of patients in mixed dentition are being treated by the general dentist. So posterior crossbites, deep overbites, anterior crossbites, open bites, tongue thrust. I'm going to show you a few of those cases tonight, and I hope you enjoy them. The big thing is 70% of children have a malocclusion. So if you have a lot of children in your practice, it's very important that you learn to treat these kids because, as you know, mothers, if you're doing this, you know that when you suggest a malocclusion treatment for a mother, they always say yes. Much more apt to say yes to treating their children's malocclusion than they are to having a crown or a bridge made. Here's a patient that I used a functional appliance on to move her jaw forward in about 7 to 9 months. It was a twin block appliance, and in 7 or 9 months without surgery, I brought her jaw forward. And I treat patients as early as age 5, but certainly 7 onwards is a great time to treat kids. And I think the general dentist, again, should really invest in courses, and we have one coming up in California in October. And here's another case I did probably 25 years ago. But a dramatic change in her profile in 9 months wearing a twin block. Here's another one, 9 months wearing a twin block. I mean, this is an older case, and you can see it's not digital photography, but fantastic changes in the patient's face. And of course, you change their self-esteem. When you bring the jaw forward, you help the temporomandibular joint. You might be preventing snoring, sleep apnea later on in life. The big thing is, as general dentists, we have to look at the arches and look at the shape. The arch on the upper is a V-shaped arch, and you can see it's a V-shaped arch and a high palate. See the high palate here? And then all we did was down below here, we expanded the arch, and you can see now the palate has dropped, and it's much wider, and now we've made room for all the teeth. How easy is that? So when you're faced with crowding, the first thing the general dentist has to think about is expansion of the arch. Develop the arches to normal. It's not really even expansion. It's making the arch that's pathologically narrow normal width, and then all the teeth will fit. That's the European approach. In North America, unfortunately, most of the cases are done in permanent dentition using fixed braces. It's getting better. Space Maintainers and speakers like me are trying to change things, but it's difficult because it depends how you're trained. If you go to school and you're trained to treat in permanent dentition with fixed braces, that's what you do when you graduate. So in North America, there's a lot of bicuspids extracted. And you general dentists know that because you're getting letters from general dentists and orthodontists to extract bicuspids all the time. You've got to try and send to someone who uses functional appliances. So there's an orthodontist in your area using functionals, or a general dentist in your area using functionals, or you take courses and learn how to do it. Develop the arches, do non-extraction treatment. The mothers love it. I built my entire practice on that. And we're busy. Now let's talk about the smile. Look at the smile here. or the future King of England, who I think had bicuspid extractions. It's never been confirmed, but certainly he's got a very narrow upper arch. His wife has a much beautiful arch, broad arch. Maybe she had a development, maybe she didn't. But anyway, that's the difference. If you expand the arch, you get a nice smile. If you don't expand the arch or extract bicuspids, you get that smile. There's one of my favorites. Jen's got a beautiful smile, broad arch, and that's what you want. Now, here's a patient I treated. Look at her. I treated her when she's, I think, around 15. She had a narrow smile on the left, and you can see a beautiful, broad smile on the right. I expanded her 10 millimeters, upper and lower, and I'll show you her case quickly. So again, let's go back to the beginning. Let's look at Joshua, age 6, and look at him, and he's got a narrow smile, and he's got no room for laterals. So that's the first thing I tell everybody in my course, is make sure there's room for centrals and laterals on the upper and lower. If there's no room for centrals and laterals on the upper and lower, you have to develop or expand the arch, period, until there's room. He's got traumatic occlusion on the central incisors. He's got no room for permanent central and laterals. There's barely enough room for the primary laterals. So we go in with a Schwartz appliance. Easiest, simplest appliance there is. Came out in 1935. It's got one screw in the middle. It's got additive class holding it in with the primary molars. You turn the screw twice a week, and you open that about 6 millimeters, and now you can see there's room for the 2 laterals and the 2 centrals. How easy is that? They turn it twice a week. There's no discomfort, and you're making room for the front teeth. You wear it all the time. You take it out to clean it. You remove for sports. You adjust the midline screw twice a week. Each turns 1/4 millimeter, 2 millimeters a month. Comes in all different colors. You need to talk to space maintainers to get some color charts for them. They probably even have their website where you can look and get color charts and things. So check with space maintainers. The children want colors. They want a different design. So here's a plain one, and there's the screw they give you, and you just turn that twice a week. So here's the arch we start with on the upper left, and you can see no room for centrals and laterals. And down here on the lower right, you can see the arch is expanded, and there's room for laterals. Now, this patient never came back for braces. I think we made enough room that all his permanent teeth erupted, and he never needed braces. Now, there's a constricted arch on the lower. And you can see even the lower central incisors are crowded, and there's no room for the laterals. Again, you need to expand the lower arch. So again, we use a removable appliance on the lower, and we expanded 4 millimeters. And it's easy. Adjust it twice a week, and then look at the final arch. I mean, look at the difference in the upper left, where you have a constricted lower arch, no room for laterals, and look at the lower right, and you can see there's lots of room for centrals and lateral incisors. Big change, very easy. Turn the screw twice a week. Mothers love it. And the advantage is, of course, you improve nasal breathing. Okay? You have a broad arch, easier to speak, and a beautiful smile. I mean, there's all kinds of advantages. And again, you can see there's his centrals and laterals have erupted. Big difference. On the upper left, traumatic occlusion, no room for teeth. On the bottom, everything's erupted beautifully. And again, look at that lower arch, nice and wide, room for all the teeth. And again, he never came back for permanent braces because stage 1 or phase 1 was successful. If you make enough room for all the teeth, the chances of coming in are much greater. Charged him $2,000 for an upper Schwartz and a lower Schwartz. Probably the lab would charge me maybe $100 to $125 an appliance. Very little chair time. The patient did the work. They turned the screws. What could be easier? That's Hawaii. That's where I like to play golf at Christmas time. Now, here's a little 5-year-old guy. And, of course, he's not a good cooperator. He's 5 years old. I think if you're 5 years old and not a good cooperator, you've got to use a fixed appliance. Now, the constricted arch, you can see there's crowding with the lower incisors. Right here, the lower incisors are crowded. Okay, so, and there's no room for the laterals. And certainly, how are you going to get 4 permanent teeth on the upper arch with those 2 small central and lateral incisors. You need to expand. So I'm going to be, he's a poor cooperator. Most 5-year-olds are poor cooperators, especially boys. And so we're going to use a fixed appliance. So this is a transverse appliance, and actually Space Maintainers helped develop this with Dr. Clark. They did some of the research on this. So anyway, then we just want to expand. There's a mid force module right in the middle with nickel titanium coil springs within the force module. And when you put it in, it just expands by itself. You don't have to do any adjusting. So you put it in and you measure, see where it's measured, 4 millimeters? Measure that part, because the force module to the right of that does not change shape. So the shape will change with the marking on the left. So watch. You can see now in maybe 3 months or so, the 4 millimeters changed to 8 millimeters. And we didn't have to do anything. We just put it in, and it worked by itself. Okay? There's a nickel titanium coil spring, which works completely by itself. And there in 4 months, we've got enough expansion now that first of all, the lower centrals are now straight. See above, they're crooked, and now below, they're straight. And 2 centrals are coming in now, permanent centrals on the upper arch. And we just keep expanding. Now, we did the upper arch, and now we have to expand the lower arch. Okay, so we're going to use the lower arch, and you can see we started out at 6 millimeters in the lower arch. And now we've got it on the upper and lower, and you can see how comfortable it is to wear. There's nothing between the teeth. It's completely adjustable. The parents love it because they can't take it out. The child can't remove the appliance. And there the arches are expanded. I mean, how easy is that? You just cement it in, it works by itself. There's no adjusting. So we had a constricted upper arch, no room for centrals and laterals. Now in the lower, you can see the 2 centrals are in, the 2 laterals are coming in. On the upper arch, there's room for the permanent lateral incisors. Now look at the arch. Look at the difference in the arch. On the picture above, you can see crowded laterals. On the lower, much straighter, and there's room. Much nicer arch. You can see there's more room for the tongue. It's easier to speak. And now you've got a chance for all the permanent teeth to erupt. I mean, this is what you want to do. If you've got your younger children in your practice, no room for laterals, constricted arches, get in there with removable or fixed appliances, help these children develop properly. Forget extractions. Forget waiting until they're 13 or 14 and they go in with all kinds of crowding and somebody suggests extractions. It could be done so easily when they're younger. Look at the difference in the arches. You can see there's lots of room now for the lateral. That's the last photo I have of him. He must have moved away because he never came back for treatment, but maybe he never needed treatment. So again, we started out with a 4 millimeter opening on the appliance, and it went to 10 millimeters. We might have had to use 2 appliances on him because each one of these transverse appliances only expands about 5 millimeters. So we might have had to use 2 appliances on him. But look how easy it is. Look how much that expanded, and it's painless. Absolutely painless. Parents love it. There's no adjusting. Just put it in. They never complain, and it works every time. No question. So there's the beginning at the upper, constricted upper arch, poor cooperator. And down below, you can see a nice broad arch, room for all the permanent teeth. Hopefully, he'll never need phase 2. So for information on my courses, just rondoseminars.com. Love to have you call and get information. Talk to Space Maintainers too. They know about my courses. Again, we're having one in October. Call 877-372-7625, toll-free number. Happy to talk to you anytime. Call Lee. She knows everything. Here I am in Turkey. Now, this was before the problems in Turkey. I don't think I want to go over there today. But that's my class in Turkey. And that orthodontist holding onto my arm was the interpreter. And he did a great job of interpreting. And what's neat about Turkey is that they do functional appliances over there. So I was quite happy. I was well received, and they were quite happy to use functional appliances. And, of course, at the end of my courses, as had happened in Turkey, we give a certificate from the International Association for Orthodontics, which has been around for about 40 years, slightly longer than I've been teaching. And anyway, and it's nice because it gives you credibility when you pass the course and get a certificate. And here's a guy very excited to receive a certificate. He's the most excited ever to get a certificate, and he's having fun. I want to show you the patient I showed you earlier with the narrow smile at age 15. Look at the dark corners in the side of her mouth. That's what you don't want. You want to see teeth right to the corners. So we started out with these constricted arches. And maybe if she'd gone some practices, they might have said it's too much crowding, especially that cuspid on the lower right blocked out. They might say, you know, we need to extract some teeth. But we put in a Hyrex appliance and expander 10 millimeters. And we look at that cuspid on the lower right. You can see that for sure that's blocked right out of the arch. Very tempting to maybe take out a bicuspid, but we didn't. And we expanded her with a lower fixed expander. Now that's got a nickel titanium corrosion you can see. And expanded her with that and I think we used 2 appliances in the bottom because the first one only got 6 millimeters. And then we kept expanding. And that's right after expansion only, no braces. So that slide that you see, the photo, is her right after just expansion of upper and lower arches. I mean, look at the difference in her smile. You can see teeth right to the corner of her mouth now. Beautiful, beautiful smile. And then we put brackets on. And then we use a retainer with a clear labial bow, which is kind of nice because they can't see it. And there's the difference in the arch. I mean, that you cannot get that with braces. You can't get that kind of an arch development with braces. And look at the tongue position. Look at the picture above with the tongue back. Everybody knows tongue back, snoring, sleep apnea later on. Picture below, tongue forward. Okay, tongue can come forward when you give a proper size upper and lower arch. You're making people healthier and maybe living longer. And certainly all of you should maybe consider taking a course in snoring and sleep apnea too, because that's a real important subject also. So there we put a lingual bond and retainer in the lower to make sure the teeth don't move because they were very crooked in the beginning. We put a lingual bond and retainer in the upper, as well as that upper fixed retainer with the labial bow that was clear. There she is, and there's the difference. And you can see what a beautiful arch. And big difference. That cuspid is blocked right out of the arch, and we made lots of room for it. The other side worked beautifully, just a different face. Different face, different arch, room for all the teeth. And look at that smile. I mean, that smile for life is fabulous. Every time she smiles, she thinks of me, I'm sure. And I know that my nephew says that every time he smiles, he thinks of me because I made him look almost as good as her. Anyway, there she is, a narrow smile. There she was, a great smile. So you want to learn to develop arches. She might be wearing her retainer there. I think she is. She's wearing her clear retainer over those teeth, and you can't even tell. Okay. So let's talk. So that's the first few cases I showed you were develop arches. Now let's show you how to treat a simple little crossbite. So here's a little 8-year-old girl, very pretty girl, coming with a crossbite. Now the mother doesn't like that crossbite. The mother wants to find someone who can fix it. You tell the mother, we can't fix it. She looks at you in disbelief. When you think of the things we can accomplish in the world, and we can't fix a crossbite on an 8-year-old, she can't believe it. But you know the problem? Nobody's advertising this on TV. You don't see TV programs about this. You don't see it in magazines. You have to educate the patient in your own office. So there's a patient with crossbite. Obviously, we have to open the bite. You have to open the bite and move that front tooth forward. So we make an appliance with posterior pads. So tell space maintainers, you want 2 millimeter posterior pads enough to open the bite. And then you want a screw behind that tooth, which you're going to turn twice a week, to move that tooth labially. Now, you can use finger springs if you want, but they're a pain in the neck to me. I'd rather just put a screw there, turn it twice a week, and that tooth will be corrected in about 2 months. So actually, it opens 2 millimeters a month. So in 2 months, it opens 4 millimeters. The crossbite's corrected, but you must open the bite with those pads. And there it's once, and now it's corrected. So now it's corrected. So it's corrected. Look at the difference in the bone. It looks like someone took a hammer to the upper central incisor of the bone, and look, it filled in beautifully just by correcting the anterior crossbite and getting rid of the traumatic occlusion. So again, look at the difference in the bone on those two teeth. And how easy was that? That was a little appliance that maybe was $125. I I'm not sure exactly what they charge, but maybe $125. It's different in Canadian funds, right? You're U.S., most of you. And, I mean, you charge $1,500 or whatever for the case, and the mother is so appreciative, and she came back to me for braces. She came back to me for braces. Okay, so I'll show you very quickly how we finished the case. But look how beautiful it is. Look, just moving that tooth out. Why would you leave that tooth like that for from 8 to 13, 5 years, have her walk around and not want to smile? That girl didn't want to smile. She was ashamed of her front teeth. And if you don't do it, I guarantee you, in this day and age, the mothers are going to find someone who can do it, and you might lose the patient. You're not only losing the income from doing it, but if the mother finds someone else who's smarter than you and can do it, they're going to go to someone else. So you general dentists need to learn how to do this. This is simple. Okay, look at the difference in her smile. Weak smile to start with, broad smile later on. Now, I charge $1,500 for that case. I charged $500 for records. So that was a $2,000 case that took me very little time. It could be done in another room when I'm doing, if you're doing operative dentistry in one room, you could be checking the appliances in another room. So it's very, very appreciative by patients, and it's very well rewarded for you to do the work. So she came back to me, and in the upper left corner, you can see that's what she looked like after she became 12 years old. Came back to me, and I said, we can straighten these teeth in 12 months with braces. The mother would say, let's do it. Okay, so we put the brace on for 12 months, and there's the final result. And so you can see, crossbite was corrected early on. It stayed corrected, and all we had to do was put braces on and straighten those teeth out a little bit. And then, of course, we put a lingual bond and retainer on so the tooth won't go back and those teeth won't move. And you leave that retainer on for 10 years or more. So there's the crossbite corrected. Easy, easy, easy. Look at that beautiful smile. Look at that beautiful broad smile. I mean, gorgeous. If those children at 8 years old don't want to smile, it's bad because it's bad for self-esteem. The children, their friends think she's unfriendly because she won't smile. And once you correct that crossbite, you can see they smile beautifully.
Whoa, really?
Okay. So anyway, the ortho fee in my office is $6,500.
Nice. Ralph Lauren.
She paid $1,500 for phase 1. So phase 2 was $5,000. So I got $1,500 plus $500 for records, and then I got $5,000 for phase 2.
I can barely afford one pair.
Anyway, another patient. Now we'll do some open bites. Here's a patient with an anterior open bite at 5 years old. Now the slides are a little old and not quite as clear because I did this case maybe 15 years ago. But I want to show you a 5-year-old guy with a 7mm anterior open bite. If you don't treat him, it's not going to close by itself. He's got an anterior tongue thrust. He puts his tongue between his teeth every time he swallows. So we have to make him a tongue crib. So we make him an upper appliance, expands the arch, and we put that tongue crib. And that tongue crib is going to prevent any tongue from going between the teeth. So it's a banded Hyrex with 2 bands on the primary molars and a tongue crib. So his tongue's not going between those teeth. So there you can see his tongue is not going to go between the teeth anymore, and the bite closed down. Here it is at age 8. His front teeth have erupted. I expanded his upper arch a little bit, and that bite closed down. So I started him when he was 5. The appliance was probably in for about 6 months. Took the crib off, and it corrected the problem. As long as the crib's in for at least 5 months, it usually corrects the problem. So now I'm going to show you. So again, the fee was $1,500. The records are $450, $1,950. I didn't do any work. I just put the appliance in. The appliance does the work. Here he is at age 12. Mother came to me and she said, does he need braces? Well, I said, how much money do you have? He looks pretty good. I mean, the lateral incisor is not touching, but he's got good posterior occlusion. He's got good anterior occlusion. I mean, he looks pretty good. So the mother never came back to me for braces. Certainly, we could have done braces on him. If they'd been a little more financially stable, we could have, but he doesn't look bad. So that was a pretty good case. Again, the neat thing is, if you do phase 1, sometimes you don't even need to do phase 2. So there he is at age 5, and there he is at age 12. Happy patient, no braces. Charge them about almost $2,000, and the parent very appreciative. Doesn't need phase 2. So sometimes when you do phase 1, they don't need phase 2. So you can certainly build it up. Now I do have something you may be interested in. I've got a fantastic early orthodontic treatment conference in Vegas at the Paris Hotel, September 30th and October 1st. I'm just going to show you very quickly. I'm, of course, speaking. I have an orthodontist, Dr. Kent Lawson, who wrote an unbelievable book, which I give all the new patients, and he's talking about New Orthodontics Explained. He's actually setting up franchises all over the United States, specializing in early orthodontic treatment. And he'll be telling people about that at my meeting. But he's unbelievable. Here's a guy, Dr. Mike Bubon. He's an orthodontist. These are all doing early orthodontic treatment. They specialize in that. Most of their patients are younger. He has 11 orthodontic practices. I'm going to ask him to please tell us how come he can have 11 practices and I can only have 1. Actually, I don't want 11, I don't think. One's enough. But, I mean, he's obviously got some good marketing ideas. Here's a general dentist friend of mine who teaches at the university. Teaches orthodontics at a university in California. And he's also showing early orthodontic cases. Here's an outstanding pediatric specialist who has hundreds and hundreds of orthodontic cases, and he's going to be showing many of his cases. So I urge you, if you want to hear some of the best in the world on early orthodontic treatment, I urge you to come. We've also got a web specialist coming to talk about how to create, Facebook and attract new patients and websites and everything else. And I have an MBA grad, a tremendous guy on practice management talking about practice management, how to build your practice. So again, I don't want to promote it too much, but that's something you may want to consider. So call our office, and I think we'll give you some kind of a discount to go because it's in a month. There's another pace manager Overbite. I'll go quickly with this, but again, you can see no room for laterals. So no room for laterals, you have to expand. So you've got an anterior open bite, you have to use a crib. Okay, cause is the anterior tongue thrust. So you got to put a crib in where you can't stop the tongue thrust. Make sure you don't have large tonsils. If you have large tonsils, you can't use a crib. You have to get the tonsils out first. Again, look at the arch, very easy, no room for laterals. You have to expand, period. Otherwise, and again, when you expand, you'll make more room for the tongue. So here's the tongue, no room for laterals. Let's expand upper and lower arches. So there again is the maxillary banded hyrax with a tongue crib. I know it looks like quite an appliance. You might feel badly about putting in some young children, but if you don't do it, you can't stop the habit. And they'll still have a habit when they're an adult. So you got to do it. So there it is. I know it looks like quite a contraption, but it works. So put that in, only in there for 5 months, and the bite starts closing immediately. As soon as that tongue doesn't go in between the teeth will erupt. So in 2 months, it's starting to close down already. 2 months, it's closing down. Mother's happy, everybody's happy. He can eat, he can talk, he's fine. When you make more room in his mouth, he's got more room for his tongue. So here I open the midline screw, 6 millimeters. Now I take the crib off after 5 months, but I leave the hyrax in for another 6 months to hold to prevent a relapse. Okay? So it looks like we expanded even more. Looks like we expanded above 10 millimeters. It expanded because those laterals in. Again, now we put separators in because we're putting bands on the lower molars. So there's the bands on the lower molars. Again, turn it twice a week. And there's a lower expansion appliance, fixed appliance. Both were fixed, upper and lower. The cribs have to be fixed. So we're expanding the lower incisors, making room for the laterals. Look at how much we've expanded, maybe 6 or 7 millimeters. Now we have room for the lower laterals. So again, we're making room for the upper laterals, the lower laterals. Restricted arches, expanded arches. How easy is that? The patient turns the screw. The mother has to be taught how to turn the screw. That's the only thing. It's a little more complicated when you're using a hyrax than the self-adjusting appliances I showed you earlier. So again, narrow arches, wide arches. Now, mother will frequently want those teeth straightened. Great. She wants to have nice broad arches. She wants to stop the habit. But you can see in the upper left picture, she's got crooked front teeth. So we bracket from primary cuspid to primary cuspid. And we bend those sectional arch wires. We teach that in the course. Or you can use just a regular arch wire. And we line those teeth up in 2 months. I mean, how tough is that? Put the brackets on, use 2 wires, and the teeth are straight in 2 months. And they pay you for this. They pay you for this, and they appreciate it. Nobody ever said thank you for any filling I ever put in. And I put in lots. But when you straighten the teeth in 2 months, they all thank you. And they hold the mirror up, and they are all excited. Okay, straight teeth in 2 months. Okay. The fee was $3,000. Upper fixed habit appliance with a tongue crib. Braces upper anterior teeth. The brackets cost $5 a piece. So it's not very much money. And you can see I charged the patient $3,000, which is a very fair fee. And they got a great result. 2 appliances and 6 braces. Started out no room for the laterals. Look at them, no room for the laterals. And look at that, room for the laterals, straight front teeth, expanded arch. Hopefully all the permanent teeth will now erupt. And she may never need braces. If she does, maybe 9 months. And they'll come back to you because you remember you're giving them a credit. She comes back for braces, I take $3,000 off the cost of the braces. So maybe I'll charge her $7,000, I'll take off $3,000, I'll charge her $4,000 for the braces. And they're very happy because if they go somewhere else, they won't get a discount. Look at the difference in the lower arch. Lots of room for teeth. Again, big difference, but easy. So remember, no room for laterals, you expand. Crooked teeth, put on 6 braces. Okay, what are you going to do about a deep overbite now? This guy's coming to me at age 11. He's got a deep overbite. And he's got headaches. Okay, I'm hoping all of you are using a TMJ health questionnaire form. And I'm not showing all the records with these cases because I'm just trying to show you an overview of a bunch of cases that you can easily do as a general dentist. But all of these patients have TMJ health questionnaire forms. And he filled out the form. And this 11-year-old boy has headaches due to temporomandibular joint dysfunction. He's overclosed vertically, and he's got a TMJ problem because of that. So we have to open the vertical. Okay? Got a class 2 molar relationship. You have to bring his lower jaw forward. There's his profile. You don't have to be a rocket science to see that the upper jaw is in the right position and the lower jaw is not. You've got that crease under the lower lip. You need to bring the lower jaw forward without surgery. 11 years old. And that's my Rickinator, developed by a dentist called Rick Gallagher in the U.S. He showed me this appliance about probably 30 years ago. And there it is. So it's an upper bite plate, which is index. The lower incisors fit into those little spots, and you can't go back. Okay? So there he is. In the upper picture, he's got a deep overbite of 6 millimeters. On the lower picture, he's biting into his Rickinator with a 1 millimeter overjet and a 1 millimeter overbite. And we've done composite buildups at the back to fill in the space so we'd be able to chew. And you can see the first molars are there and they can erupt. So those first molars will come up in 2 or 3 months and they'll erupt on their own passively. You don't have to put any elastics or anything. They'll just erupt on their own. And you leave the composite buildups on those primary molars. You can see the Rickinator ramp and the lower incisor biting in front of the ramp. You can see the composite buildups on the primary molars, and they'll stay there. You've established a new occlusal plane. Okay, so now the molar, first parent molars will erupt to their proper level. The bicuspids will erupt. The cuspids will erupt. You've got a new occlusal plane established, and you've immediately eliminated headaches. You brought his jaw forward, moved the condyle down and forward, which is the way to move it, not up and back. Many of us were taught up and back, not good. Down and forward is the way to go. Again, the other side, the same thing. Do the build-ups. So put the Rickinator in first at a 1 millimeter overjet, 1 millimeter overbite, and then you just do the build-ups to fill in the space. Otherwise, you can't chew, and you have TMJ problems. You must support the condyles. So look at the difference. Left, he's got a 4 millimeter overjet and a 6 millimeter overbite. On the right, wearing the Rickinator, immediately He's got an overjet of 1 and an overbite of 1. And you leave that in for 6 to 7 months. And then they stay there. They actually stay there. There he is, half an hour later, after putting the Ricinator in and doing the billows, maybe an hour later. And you can see his eyes even look better. He's happier. He's in a better position. And look at his profile. Look at the difference in the profile. We've increased his face height. Now, it's a little misleading because one head's bigger than the other. But even that, you can see that. Look at the submental crease on the left. And look at the submental crease flattened out a little bit on the right. He looks more handsome. I mean, that's an hour later. He looks a year older. He looks great. His head position's better. His posture's better. His temporomandibular joint is fixed. His headaches are gone. His malocclusion is fixed with one little appliance called a Ricinator, which space maintainers make hundreds and hundreds a year. And you do 4 buildups. And there he is. That's the final result. Okay, so we put braces on him at the very end. The mother wanted him to be completed, so he had a few crooked teeth, put the brace on and finished him. Okay, so you will get the patients coming back for phase 2 if they need it because they're happy with you and they come back. Now let's talk a little bit about class 2s. The general dentist has to make up his mind what philosophy he wants to follow. Does he want to follow the retractive philosophy? So again, I'm going quickly, but these slides can be looked at later, and you can go slower on the internet. Most orthodontists and most general dentists, I think, are doing fixed braces with permanent dentition. Because the majority of the courses out there are fixed braces, permanent dentition. Bicuspid extractions are prevalent, but getting better. Cervical faceful headgear is still being used, but less lately. You retract the maxilla when you take out the bicuspids. You end up with a thin maxillary lip. You end up with constricted arches, narrow smiles, and no improvement in TM dysfunction. You don't want to do this. Here's what you want to do. Space Maintainers and Rob Weiss has built a company on the functional philosophy. Okay? You treat in mixed dentition with functional appliances. If you've got a crossbite, anterior, you fix it. You got a posterior crossbite, you fix it. If you've got lower jaw deficient, you bring it forward. Upper jaw deficient, bring it forward. I'm not going to show you too many class 3s today. It's non-extraction technique. Functional jaw repositioning appliances. Advance the mandible, end up with a full maxillary lip, end up with wide arches, broad smiles, and a healthy TMJ. That's where you want to be. You want to take a course that does this. If you take the other courses, I think you're doing your patients and maybe yourself a disservice. Because we also teach functional, we also teach straight wire in our courses. But you have to start with a functional philosophy. It helps the TMJ, it helps the snoring sleep apnea, and it helps the malocclusions. And it helps to prevent surgery and extractions. And what mother wants their child to have surgery and extractions? Zero. Nobody. So what about malocclusions? Well, the majority of malocclusions are actually class 2, 70%. Class 1s are 25, class 3s are 5%. So say you don't want to do class 3s, well, do the rest. Now, if you see models, and if you see where the upper jaw is and the lower jaw, you can see that one is behind the other. In most malocclusions, the mandible is deficient. Okay? In 80% of the cases, you have a normal maxilla and a retrognathic mandible. So why would you ever consider extracting bicuspids in a case like this when the maxilla is normal? Leave it alone. If the mandible is the problem, bring it forward. So here's a case I did a long time ago, and you can see she's got an underdeveloped mandible. Brought her forward. She looks beautiful. Again, a twin block or a Ricinator or whatever. I'm urging you, don't focus on the economy. Focus on your economy. Your economy is your practice. Your economy is getting patients to go for treatment that you can deliver. And all of them go for early orthodontic treatment. I don't think I've ever had a mother who had any money in the bank at all ever tell me that she doesn't want to treat her kids. They go without, so they'll treat the kids. So this is very good for you, and I'm happy you're all listening tonight. I really hope that if you don't even take my course, take a course on functional appliances somewhere. You need to offer early orthodontic treatment for children. Concentrate on your economy. Okay? Build your practice. Offer non-extraction treatment. Offer non-surgical treatment. Have brochures made up that that's what you do. Put that on your website. Let people know what you do. Here's a patient. You see I look much younger there. There's a little black in my hair, and so that was probably, I don't know, 20 years ago, 25 years ago. This little girl was going to a psychiatrist due to her headaches. The physician didn't know where to send her. You can see the pictures are pretty old next to her. She had a 7-millimeter overjet and a deep overbite. I brought her jaw forward with a twin block and immediately got rid of all her headaches. It happens routinely, and nobody could help her. And the doctor thought she was crazy because he couldn't figure out what was wrong with her headaches. And all she needed was to have her temporomandibular joint moved and her mandible moved. Headaches eliminated with a twin block. You saw that patient before. Here's another twin block patient. It's easy. Anybody with a retrognathic mandible, bring it forward. Look at that little guy. You don't think I changed his life? I mean, who's going to hire the guy on the left? The guy on the right looks strong. He's got a nice, strong mandible. Brought him forward when he was 7 or 8 years old. That's the guy you saw earlier with the originator. Here's another patient. Brought her forward with a Mara appliance. You can see the one on the right is 2 years later, and she looks younger than the one on the left. The one on the left has got short lower face height. Her mandible's back. She looks older. Okay, so there's our Level 1 course in Orange County. Check the website, rondoseminars.com. I guess if you take the course tonight or sign up, we're going to save $300. Well worth it. One ortho case pays for the whole course. So the course is online, and it's also live. So 4 sessions. Look on the website for more information if you're interested. Again, my course, I have a membership benefit, a case diagnosis at the end online, and I'm not going to get it. I've got maybe 30 or 40 articles online that you can read, and anyway, we're happy to help you. There's one of the cases submitted, and I would go back and send the results back to him, and everybody else can see that the case was submitted, and I diagnosed 750 cases, and you get credit online for AGD credits and your dental board credits. So again, there's the number. Now here's the case you're going to love. Okay, here's the case you're going to love. Okay. Buck teeth, age 10. Okay, what are you going to do? Let's say that little girl walks into your office. There's what she looks like in the front. Do you think she's smiling a lot? She's kind of self-conscious. She's not really happy with the buck teeth. And there's her profile. You think she looks good? No, she doesn't look good. Her mandible is way behind her maxilla. Her upper lip is perfect. If you cover up the lower jaw and look at the upper lip and the nose, she looks perfect. She has not got buck teeth. She's got a retrognathic profile. Got an overjet of 10. So what are you going to do with this little girl? Are you going to send her to someone who does an orthodontist or a general dentist who does retractive orthodontics? And they're going to take out her upper bicuspids and move her upper lip back to match her lower deficient jaw and make her look like she was hit across the face with a baseball bat? Is that what you're going to do? Or are you going to find an orthodontist or a general dentist who use a functional appliance on her? Hopefully you're doing it. If not, you need to do what's best for this patient. And you can see by looking at this picture, there's a huge difference between where the maxilla is and where the mandible is. Look at the bone. It's a bone problem. Not just a tooth problem. It's an orthopedic bone problem. Okay? And she's biting on the roof of her mouth. So there she is biting the roof of her mouth. 10-millimeter overjet. You got to bring the jaw forward. So I used a banded Hyrex and a Mara. Okay? And actually an orthodontist discovered the Mara right in California. Jim Eckert. Right there in California. And he discovered the Mara probably 25 years ago. And it's a fantastic appliance. Okay? So the first thing you have to do is develop the upper arch. All class 2s, when you bring the lower jaw forward, you'll be in a buccal crossbite. So the first step for all class 2s is expand the upper arch. And when you bring the lower jaw forward, make sure you're not in buccal crossbite. Okay, so that's a Hyrex. Going in first, expanding your 6 millimeters. There's the overjet of 10 millimeters. Now, it's really simple to see if you're doing the right thing. Have the patient advance the mandible to an ideal overjet, ideal overbite. Okay? Just bring them forward. Now, I brought her forward to a 1 millimeter overjet, 1 millimeter overbite, and looked at the side of her face. Make sure you let the parents do that too. Have the mother say, what do you think? And the mother say, she looks gorgeous. And show them the two pictures. Picture on the left, the patient's biting in their back teeth with a 10 millimeter overjet. Patient on the right, the patient's brought the jaw forward with a 1 millimeter overjet. I mean, you know right away that that's the right treatment. Can you see how bad it would be if you extracted the upper bicuspids on her? She looks gorgeous. So what's your choice? Are you going to send to a clinician who says you need surgery? Come back when you're 17, we'll do surgery. You'll have braces from 17 to 19. Or you're going to do it yourself, or you're going to send to a clinician that knows how to use a Mara, because the Mara is the appliance of choice, or a Herbst. Okay? So there's the Mara. I haven't got time to really go into this appliance. We teach this in the course. I'm sure that you can get articles. I have articles on my website on the Mara, and space maintainers make these all the time. And they make the Herbst. And so it's got an elbow coming up from the upper and an arm coming out from the lower. And you can see when the patient tries to move their jaw back, the arm hits the elbow and they can't go back. So they're held forward. You have to do it in stages. You can't do it 10 millimeters at once. Again, I can't really teach you how to do everything tonight, but I want to show you what's possible and encourage you to try and take some courses to teach you this. So again, there's the upper part, there's the lower part. There's the Mara in place. Bring your jaw forward. That's probably after several months because you can't move it 10 millimeters all at once. And then so she could chew, I put blue Bisfil composite. Today, actually, I'd probably use white because some of the kids object to seeing the blue back there. But you can put blue or you can put white. Just build the bite up. I'm completely changing everything. Then we have a deep overbite, and we put in a ricinator. After you take out the Mara, you got to use a ricinator for 6 months. The Mara's in for 7 to 9 months. Then we do braces, and we erupt the back teeth one at a time. And again, we show this all in the course, and there she is at the end. Okay. Quite a difference. Beautiful broad arch. Standard probably 6 or 7 millimeters. Brought her lower jaw forward. She's got a class 1 molar relationship now. She's not biting in the roof of her mouth anymore. Got a 1 millimeter overjet, 2 millimeter overbite from 10 millimeters. And there she is. I mean, she looks gorgeous. Quite a change. Quite a change. And look at the upper, there's the upper and lower arches. And there's that nice QCM lingual or upper retainer, clear labial bow. They wear that for a year. And there's the difference in the profile. I mean, that's the difference in the profile. From a 10-year-old, she's probably about, on that picture on the right, she's probably a 13 or 14 now. But just a different person. Look at the smile. I mean, from buck teeth at age 10 to a drop-dead, gorgeous smile at age 13 or 14. I mean, bristling with confidence. Changed her whole life. Changed her look, changed her life. Then she brings in some pictures. She says, Dr. Ron, I've decided you made me look so nice, I want to be a model. I'm a teenage model. I said, I don't think much of your genes. Oh, quite a few rips there, you know. She says, no, that's normal. There she is. And that's the picture that's worth 1,000 words. I mean, that picture of her just smiling at me, showing off her new smile, and so proud of her pictures, and so proud of her, how she's developed as a person. Now she's about 15. She brought those pictures to show me. I mean, she just looks beautiful. So happy with her smile. Okay, so cases like that make you want to go to the office in the morning. So here I am, almost 74 years old. Okay, I'm thinking of my longevity. I work 6 days a week. I take Sundays off. I teach 3 weekends out of 4. And I actually look forward to it, just like I was looking forward to the webinar tonight. I must be a very sick person. But I really think I'm making a difference in patients' lives. I get all kinds of compliments from the dentists who take my courses, saying that now they love dentistry. Now they don't want to give it up. They're bored with doing fillings and root canals and extractions, and they'd like to do something else. And orthodontics, you have to use your brain. You have to motivate the patients, and it's fun. So if you don't want to travel, take the internet course. And this is a sample of what you see. I mean, tonight is now on the internet. I go a little slower. And explain carefully all the records for all the patients and how you adjust the appliances. Let me just show you one more, class 3. Okay, I make it go all night, obviously, but let's show you one more case, and then probably some of you have questions, and I'm very happy to answer them. And so here's a little girl who's 5 years old. Again, picture her coming into your office. She's coming into your office just like all these little kids are coming into your office, and what are you doing about it? Okay, they have all these malocclusions. Are you telling them, like we were trained in dental school, come back when all your permanent teeth are up and I'll send you to an orthodontist? Okay, but then you have to ask yourself, does your orthodontist use retractive orthodontics or he does functional appliances? Again, I'm going to suggest you send to an orthodontist or a general dentist who does functionals, or you learn yourself to do it. So here she is. Can you see the deficient upper lip? Look at the profile. Now let's say you know nothing about nothing, and you just want to make that patient more beautiful. What do you want to do? I think you want to convert her from a concave profile to a convex profile. You need to give her some fullness in the upper lip, and you cannot do that with braces alone. You need space maintainers, functional appliances to fix her. That's the only way you're going to do it. And here she comes in with a class 3 molar relationship. She's 5 years old, and she's got this tremendous overbite and this anterior crossbite. So what are you going to do? You're probably saying she probably was too young to do anything. She won't cooperate. But you know what? You'd be surprised. You can tell from the oral hygiene. She's doing a great job of brushing. You can tell from talking to the mother. Great attitude. So let's give it a shot. What do you got to lose? If she's not old enough, you wait a year and treat her in a year. Obviously, you have to open the bite. You can use plastic on a functional appliance and open the bite, or you can use composite buildups on the teeth. I prefer the composite buildups because they can't take it out. Remember, the appliance comes out for sports and to eat sometimes, and to clean it. Do the composite buildups, and the most amazing thing happens. The mandible rotates down and back, which improves the class 3. Look at how these teeth have worn down. Look at the lower and central incisors, how short they are. Look at the upper central incisor. This poor little kid's been bruxing like crazy. Now, if you left her on the upper left photo, how are her permanent teeth going to erupt? Exactly the same, if there's even room to erupt. So I put the buildups on to rotate the mandible down and back and to allow eruption of the central incisors. Okay? So very simple. Just do 2 buildups. Leave a couple of millimeters in the anterior. Let the teeth erupt. If they need more room, add the buildups. Look at the difference between the molars. Look at the distance between the molars. Huge. Okay? But those will erupt. Those teeth will erupt. Again, do the buildups and just let things happen. And now we've got 2 lower centrals erupting. Now we've got 2 upper centrals erupting. And she's developing traumatic occlusion. So what do we need to do? We need to move the front teeth forward, the upper teeth forward, right? So what about an anterior sagittal? There it is. So she picked Snoopy. She picked Blue. She picked Snoopy. You've got 4 class. You've got 2 screws. You turn the screws. The teeth go forward. So you open the bite a little more. Get rid of the traumatic occlusion. Allow room for the teeth to erupt. Again, you're establishing vertical. Boy, you know a denture patient who's overclosed vertically. What do you do when all the teeth are worn down? You put in a denture with larger teeth. You open the vertical. You've got to do the same thing for the children. Open the vertical to normal. You get rid of sore muscles. You get rid of TMJ problems. You get rid of bruxing. You make more room for the tongue. They can speak better. There it is. Open the screws 5 millimeters. The front teeth are going forward. Now look at the difference in the profile. I put in a space maintainer's appliance, a functional appliance. They turned the screws for 3 months. I did 4 build-ups on teeth, and look what's happened to her face. She now looks almost convex. She looks beautiful. Looks beautiful. I mean, do you think the parents appreciate it? Show them those pictures. We show you how to take these pictures in the course and show the pictures to the patient. I mean, they will tell all their friends, and you'll be busy, busy, busy. We average about 5 new patients a day. Okay, now that's not bad for braces and early treatment and TMJ and sleep. Okay, so look at the difference. My heavens, look at it on the left. The deep overbite, the class 3 skeletal. Look at the bones. Look at how the lower jaw is in front of the upper jaw. All I did was open the vertical. The mantle rotated down and back, and I moved the front teeth and the bone forward. Come on, you can't do that without composite buildups and functional appliances. I mean, and the patient does the work. She's turning the screws, not me. Okay, and there we are. Now the permanent teeth are erupting. What's that worth? What is that worth? You want to do that surgically at 17 when you can do it with 4 buildups and a functional appliance at age 5 or 6? Come on. It's ridiculous. So easy. I guess everything's easy when you know what you're doing. And this is not difficult. And they appreciate it. Do you think that mother is happy with me when I show her these pictures? She can't believe it. Okay, you might have trouble believing it, depending if you've done it before or not. So anyway, there's the overjet, there's the overbite. Again, build up the teeth, make room. Look at the molars are up. Remember the big space between the molars? I showed you before. Now they're almost touching. Okay, and the low and the centrals and laterals have erupted. I mean, it's an easy case when you do it right. Again, her face looks so much better. Deficient lip, full lip. Crossbite, no crossbite. Class 3 molar on the top, hopefully class 1 molar on the bottom. Now, with class 3s, you leave the deep overbite. You don't put an auriculator. You leave the class 3, you leave the deep overbite, and you trap the mandible and hopefully hold it back and keep it from coming forward. So you do a class 3 different from a class 2 or class 1. Class 2 or class 3, you fix the deep overbite. Class 3, you don't. You leave the deep overbite. I've taken a class 3 skeletal and made her a class 1 skeletal with 4 buildups and 1 little anterior sagittal with Snoopy on it. And there she kind of is. I mean, pretty little girl. I mean, she looks, look at the upper left photo. I mean, she's overclosed vertically. She looks older. She doesn't look friendly. And she's a cute little kid. But she's much cuter on the lower, on the right. And she's a happy little girl. And she knows, or she will be told, that no surgery and no extractions. And you show those pictures to mothers, and you've got a patient for life. So anyway, that's kind of, I guess it's an hour. I said I was going to speak for an hour. I've obviously got, I could talk a little. Let me just go through this quickly for you. In Ontario, presently, look at the last 4 lines. Presently, 42% of the practices in Ontario report they are slow. This number will increase by 50% by 2024. So we're really, as you know, there's so many dentists that are graduating now. They're just flooding the markets. You've got to get yourself established as somebody different, doing different things. The University of Toronto has announced that it's increasing enrollment by 10%. Why? Because the more students in there, the more money they're going to make. Some of these dental schools are charging $100,000 a year to the foreign students. They're making big bucks, but these foreign students are graduating and they're flooding the market. Older dentists like me, I guess, are postponing retirement. It's not financially why I'm postponing. I kind of like what I do. They say the net incomes have decreased in Ontario last year by 25%. The dentists all sent their incomes in. I don't know if the same thing's happening in the States, but I kind of think we're similar. I think that you need to be proactive and you really need to start offering early orthodontic treatment. Corporate dentistry is here. You got to compete. Where are the smaller pharmacies? They're all gone. There's no smaller pharmacy. When I graduated, there were smaller pharmacies everywhere. Now they've all been bought out by the big ones. And these corporate practices are open 7 days a week. They're open Sundays, offering all services. Lower fees. They're getting discounts on dental supplies, large marketing budgets. Hey, we got to compete with these guys. And the way to do it is by offering early orthodontic treatment. That's one way you're going to keep your patients and build your practice. So that's my advice to you. Years ago, GM got complacent. They said, we're not going to build small cars. We like big cars, you know. Gas was very inexpensive, and Toyota now are the #1 car company in the world. Because GM got complacent now. GM are coming back. Their shares are up. They're getting much better. But anyway, focus on building your practice. Mothers want early orthodontic treatment for their children. I guess that's basically it. Many orthodontists aren't treating children. I think it's an excellent opportunity for GPs to do it. And I guess my staff and I are here to help you achieve more practice success. If you're interested, that's my number. If I can help you in any way, I'd love to. I would like to end now. I hope you don't think I've talked too quickly. I have some more case to show, but I think what I'd rather do is answer your questions and just see if I can help you with any of your personal questions. So I'll now take questions, Victor.
Thank you, Doc. I'm unmuting everybody, so you can ask questions if you'd like.
I guess I mixed everybody up, Victor, in their species. So nobody sent you any written questions, right, Victor?
Not through the chat. So here we go. Just got everybody unmuted. If anybody would like to ask any questions, now's the time. No. Okay. We have no questions. Then thank you very much, Dr. Rondeau.
You're very welcome, Victor. I'm